The following is a paid advertisement of St. Anthony Hospital Orthopedics. References to any specific product, services, or entity does not constitute an endorsement or recommendation by St. Anthony Hospital, Carroll Broadcasting, or its advertisers. The views expressed by the host or guests are their own, and their appearance on the program does not imply an endorsement of them or any entity they represent. Welcome to the St. Anthony Hospital Orthopedic Show with Dr. Richard Godding. Dr. Godding specializes in joint preservation, reconstruction, and replacement surgery, and brings over 25 years of orthopedic excellence to St. Anthony Hospital and to the Carroll area. For more information about Dr. Godding, his practice, or St. Anthony Orthopedics, go to santanthonyhospital.org or make an appointment by calling 712-794-5536.
Good Sunday morning, Iowa. It's Dr. Rick Godding. Thank you for choosing to spend some time here with me today as we kind of plow into the meat of the summer, huh? It's finally that time of year, and we can expect it only to get hotter. But, I enjoy the sunlight and enjoy all that stuff. I like to go for a swim every once in a while, but I don't look forward to the late July, early August. People ask, who don't live in Iowa, how's the weather in Iowa? Well, it oscillates between too hot and too cold. And so here we are, summer. 4th of July, just around the corner now. It's just crazy how quick it happens. And so I wanted to talk a little bit today about, I think there's still a lot of people who don't really understand a total shoulder versus a reverse total shoulder and why we do those operations and what the options are. And so any total joint replacement is going to be done for arthritis 99% of the time. So essentially, the small number of reasons why you would do any joint replacement that it's not arthritis it's just so small that it's not really worth having a big discussion about. You can be certain that if you know somebody that has had a joint replacement, they probably had arthritis is why. Now, they might have had arthritis for different reasons. There are different types of arthritis, and that's worth talking about. You have sort of osteoarthritis, which osteoarthritis is generally what people talk about when they talk about arthritis. And osteoarthritis can be in any joint. It's not always in multiple joints. It can be in only one joint. You can have osteoarthritis in the base of your thumb. You can have osteoarthritis in your hip or your toe or your knee. You can have osteoarthritis in your spine. Typically, if it's in the spine, you'll have more than one portion of the spine or segment, as we call it, involved. But osteoarthritis is just the breakdown of the cartilage. And the cartilage is that substance on the end of the bone that's soft and makes it where when your bones rub together, because that's what a joint is. That's where two bones meet, right? And so by definition, there's going to be motion there. And some joints have a lot of motion, like the hip and the shoulder. Some have a little less, like the knee has a little less range of motion than the hip or the shoulder. It doesn't rotate like they do, but it goes back and forth just as much. And then the elbow has even less than the knee. I shouldn't say the elbow has less than the knee. The elbow would have about the same as the knee, but it also has a rotational component too. But that's really makes the elbow kind of a different type of joint. And the elbow is not a direct weight-bearing joint, of course. So you kind of have shoulder and hip, and then you have elbow and knee, and then after that you have like ankle and toes and things like that all have differing amounts of range of motion and differing planes of motion. In other words, the knee rotates a little bit, but not, you can make all kinds of big circles with your shoulder in different angles, right? You can't do that with a knee. It's just not that type of a joint. Same with the hip. So the hip and the shoulder are where the arm and the leg attach to the body. So they need to have more range of motion because of that. And then once they get out onto the limb, you don't need quite as much motion. Anyway, that's a big, long way of saying that different joints have differing amounts of range of motion, and you even like the acromioclavicular joint, which is part of what we call the shoulder complex. So the shoulder complex itself would be where all of your shoulder motion comes from. And some of that is your scapula or your shoulder blade moving back and forth on the back of your rib cage. So that's one plane of motion. The other is the acromioclavicular joint, the AC joint, you might have heard it termed, and this is where the collarbone attaches to the shoulder blade. And then the collarbone then again attaches to the chest wall, specifically the sternum, which is the chest plate, if you will, the front of the chest. So it really is, the shin bone's connected to the knee bone and all that stuff. But the motion in the acromioclavicular joint is very minimal. There's a little bit of rotation and just a little bit of kind of slack motion around it. So again, not much. And then you have truly what we call the glenohumeral joint, which is the shoulder joint itself, which is the ball and the socket. So all of these joints, with their differing ranges of motion, are all subjected to differing amounts of stress. And of course, when you walk all day, all of the joints in your legs and feet are going to bear weight to differing percentages, right? One of the greatest points in the body where your body weight comes across is the kneecap goes across the end of the femur. So that's called the patellofemoral, because the kneecap is called the patella. The thigh bone is called the femur, so the patellofemoral joint. And there's a mechanism called joint reactive force. And what that means is that not only is your body weight going across that joint, because when you're taking a step, but also the force of your quadriceps or your thigh muscle pulling that kneecap, the patella, into the end of the femur in order to create the motion. That's how you're walking, is your thigh muscle, your quadriceps. It's hard sometimes for me to kind of go back and forth between the medical terminology and the everyday lay terminology. But the thigh muscle or the quadriceps is going to, when you're going upstairs, it's going to exert a tremendous amount of force backwards on the kneecap in order to push up. Same thing when you're running, but with stairs, it's increased because you are going up against gravity. And it can be multiples of your body weight that goes across that little joint. I mean, the kneecap is only a little bit, about the size of between a $50 and a silver dollar, for those of you who remember $50 and silver dollars. And, 2 to 3 times your body weight going across that as you go upstairs. So it's a tremendous amount of force. So these joints are designed to slide against each other with a minimal amount of friction. And that's by having this soft but firm coating called articular cartilage. And then on top of that, you have the joint fluid, which is made up of what we call hyaluronic acid. So it's viscous. So viscous is that property that oil has, where it's liquid but it's thicker, and it's has, when you rub oil on your fingers, cooking oil, motor oil, anything, your fingers slide easier, right? So that's why we oil machines, because it reduces the friction. Gears don't injure the other gears as much when there's oil on them, right? So it's the same principle in your joints. And so osteoarthritis is one of the, so again, what I started talking about is arthritis and where you can get arthritis. You can get arthritis in any joint in your body. What type of arthritis? So osteoarthritis, classical osteoarthritis, is just a reduction in the physical properties of the cartilage that causes the cartilage to be less of a shock absorber. And in the process of that, it starts to wear away. And then eventually you can get bone on bone. And once the bone is rubbing on the bone, there's really nothing. I mean, you can inject some fluid in there and kind of try to increase the amount of lubrication by these injections that we have. You might have heard it called the chicken comb injection. These are fluid injections that we inject into joints to try to improve or reduce the friction and improve the way the joint is moving, right? So osteoarthritis is the breakdown of the cartilage, and that happens not in everybody, but in most people eventually will have some degree of osteoarthritis. And you can also have what we call post-traumatic osteoarthritis. So if you injure your knee in football or doing whatever sport or at work or whatever, if you break the joint surface. So if you break the part of one bone that is protected by cartilage inside the joint, it never grows back perfectly. That's one of the things in our body. Some things in our body, like your liver, can sort of regenerate perfectly good liver cells. Bones can mend themselves together. Cartilage, not as much. Cartilage just once there's a crack in the cartilage, it doesn't want to heal. And there's, of course, a lot of research trying to help it heal. There are some things like stem cells that can help it heal a little bit, but not regenerate new cartilage. And then, of course, we now actually at St. Anthony's are offering platelet-rich plasma injections. And those are where we spin down your blood and take the plasma portion of it, which is going to have a lot of platelets in it, and we re-inject that into your joint or your tendon to promote healing. And some people would prefer to do this rather than cortisone, or maybe the lubrication injections have stopped working for them. So that's a nice option. But those can slow down a little bit the destruction of the cartilage, but they can't stop it, and they certainly cannot reverse it. There's some claims out there that are made, but I can tell you right now, if you could build cartilage back up with injections, we would do it. If it was possible to completely reverse arthritis with injections, then why would anybody want to do a knee replacement? I certainly wouldn't want to do those operations if I knew that there was a way to just give people some injections and it regrows cartilage in their knees just perfect. It just doesn't work like that because of the lack of ability of cartilage to restore itself. So you have osteoarthritis. You can also have rheumatoid arthritis, which is where your own body sees its own cartilage as foreign and then mounts an antibody response. Now, antibodies are how the body deals with infections, whether it's bacteria or whether it's a virus or anything like that. The antibodies are going to be the way the body mounts its response. Well, for whatever reason, the body sometimes will start to see its own portions, in this particular case, articular cartilage, as foreign and then mount a response to it, and that's rheumatoid arthritis. So you see with rheumatoid arthritis, most people will have lots and lots of joints involved, and some people can have lots of joints involved with osteoarthritis too. But you really never see someone with rheumatoid arthritis and they only have a bad knee, and that's the end of it. They'll almost always have wrists and thumbs and other, spine and other portions of their body affected, where you could have somebody who injured their knee and just has post-traumatic osteoarthritis, and that's the only joint in their body that has trouble. So, and there are other types of arthritis, but those are the big ones, which is basically osteoarthritis and rheumatoid arthritis. I mean, you can have psoriatic arthritis, so people that have psoriasis, their bodies can destroy their joints as well as part of that disease process. And so in the shoulder, we kind of got off onto a little bit of a tangent talking about arthritis because I was trying to set the background for the shoulder. So a reason to do a joint replacement is arthritis. What we call an anatomic or a regular or standard total shoulder, we put a ball where the ball went and a socket where the socket was. And there's different ways of doing it. I do the resurfacing arthrosurface one because it allows you to do anything you want afterwards. And I've kind of gone into that in other shows, and most recently we had Vince on, who had a couple of his shoulders replaced, and he was able to do his Hapkido and do which is martial arts and all these things that would have been more dangerous had he not had the resurfacing type. But the essential part of that operation is to replace the arthritic part of the joint with metal and plastic. And that's the same with essentially any joint replacement. Most joints in the body, it's the shoulder and the knee and the hip are the ones that are mostly replaced. And the ankle actually has a pretty good track record, which is new. In other words, when I was training 25, 30 years ago, ankle replacements were pretty new. And now they've come into their second and third versions, and they're doing a lot better too. But back to the shoulder, and back to why would we do a reverse total shoulder? What is it? So if a regular total shoulder is replacing the ball and the socket because you have arthritis, which is the breakdown of the cartilage, which like I said, can be osteoarthritis or rheumatoid arthritis. It's essentially you're losing range of motion, you're decreasing function, you're having lots of pain. You can do a shoulder replacement. Now, if you have a rotator cuff that's torn, now the rotator cuff, we haven't talked about this at all yet. So all we were talking about was arthritis, and all arthritis is the breakdown of the joint, right? And now around the shoulder joint are the rotator cuff muscles. You can't see them. They're deep. The superficial muscles, the muscles you can see, would be like your pectoralis, your chest muscle that attaches over there and helps rotate the shoulder. The deltoid is the big shoulder muscle that if you touch your shoulder, you're pretty well touching your deltoid muscle. And the traps in the back and things like that. But a deeper layer to that is the rotator cuff. And what was noticed years and years ago, 30 years ago or more, is that if you have a patient that has shoulder arthritis and either they have an underlying rotator cuff tear or they tear their rotator cuff after the shoulder replacement, then that shoulder replacement kind of falls apart. And the problem is that the ball will be kind of moving around in the socket, but it won't be staying centered in the socket as much as it would if these muscles are attached. And so basically stopped doing shoulder replacements in people who have rotator cuff tears or who have rotator cuffs that look like they're about to tear. Then along came this French surgeon, and he presented at a conference his idea for a reverse total shoulder, which is putting the ball where the socket is and the socket where the ball is, which changes what we call the center of rotation of the shoulder. And so it allows the shoulder to be moved around by the more superficial muscles and not really be dependent on the rotator cuff anymore. And it keeps it's very stable. It's much more stable than a total shoulder, the regular or anatomic total shoulder. The trade-off with the reverse is that they're not anatomic, so we've been very cautious with letting people work and do any lifting over 35 pounds. Although what I would say is recently a lot of surgeons have become much more amenable to having their patients do a heavier amount of work with these reverses because they don't seem to be wearing out as quickly or as easily as we thought they might when we first started doing them. It used to be we would not do a reverse in anyone under 75, and now I would say probably 65. I still haven't done reverses in younger patients than that because I just think, if that thing wears out over time, over 20 years, you really don't have a lot to work with left. There's a lot of bone that takes out a lot more bone to do a reverse than a standard or anatomic total shoulder. But that is the reason why you'll know people who, or maybe you had or have been suggested to have a reverse total shoulder. That's because the rotator cuff in that patient is either not functioning, gone, or likely to tear soon. And I think a lot of people just kind of don't understand it. I mean, orthopedics is challenging to understand if you don't really have that fundamental knowledge of the anatomy. And that's kind of what I try to do with this show is help people understand either what someone else has had done in their family or what they are curious about or what they may even have to have done on their own. But that's it. Basically, joint replacements are done for arthritis. There's different types of arthritis, osteoarthritis being the most common and rheumatoid arthritis being the second most common. The shoulder is the only one where there's like a standard and a reverse type of procedure. We don't do that in the hip at all. We don't need to. We don't do that in the knee at all. And the reason for that is because the total shoulder is not as stable in there. The regular or anatomic total shoulder is not as stable if the rotator cuff is torn or damaged. So there is your quick and hopefully not too detailed. Hopefully that helps you understand. I know that there's a lot of things in orthopedics, that people don't understand, even what the rotator cuff is. Again, that's those four tendons that move the shoulder around inside. When I say inside, I mean deep to the muscles that you can actually see and feel. So just a quick little anatomy lesson today and a little principles of shoulder replacement surgery. And so hopefully you're having a good summer. And again, if you are just getting out of the fields and you have had shoulder, knee, or hip pain or something like that, find an orthopedic surgeon in your area and go check them out. And maybe you can get something done and have it all recovered by the time you have to go harvest. But I hope everybody's having a great summer, and we will be having a guest next week who lost a lot of weight and is ready to have her knee replaced, and we'll kind of talk about her journey with that. So looking forward to that, and you have a blessed week, Iowa.
This has been the St. Anthony Hospital Orthopedic Show with Dr. Richard Godding. For more information about Dr. Godding, his practice, or St. Anthony Hospital Orthopedics, go to www.santanthonyhospital.org or make an appointment by calling 712-794-5536.